for the sake of knowledge, where the nation's potentials do brood in the nest. Hail and rejoice for her noble ideals.
University for excellence, our dreams come true.
Hail and rejoice for the giant our waist. My alma mater, my alma mater, noble are thy looks and thy ideals, and great art thou in science and in arts, in all the realms of learning thou art all sublime. Hail for city of Nigeria, my alma mater. Hail and rejoice for her lofty plans.
The varsity that is sighted on soft green hills.
Hail and rejoice for her beauty's sake. Hail for city of our glory, the pride of our land. Hail and rejoice for her light will shine.
Hail varsity for excellence, our dreams come true.
Hail and rejoice for the giant our wings. My alma mater, my alma mater, noble are thy looks and thy ideals, and great art thou in science and in arts, in all the realms of learning thou art all sublime. My alma mater, my alma mater, noble are thy looks and thy ideals, and great art thou in science and in arts, in all the ranks of learning thou art all sublime.
Science and in arts, in all the realms of learning, the university is all sublime. Please, can we have To God Be the Glory, first stanza?
To God be the glory, great things he hath done. So loved he the world that he gave us his Son, who yielded his life and atonement for sin, and opened the life gate that all may go in. Praise the Lord, praise the Lord, let the earth hear his voice. Praise the Lord, praise the Lord, let the people rejoice. Oh God, to the Father, through Jesus the Son, and give him the glory, great things he hath done.
Can we please be seated? Council members of the University of Nigeria, principal officers of the university, distinguished professors and academics, my Lord spiritual and temporal, royal fathers here present, ladies and gentlemen, lions and lionesses. It is my pleasure to welcome you to the 245th inaugural lecture in the series of inaugural lecture of this great institution. As usual, before we kickstart this event formally, permit me to make some formal recognitions. Sitting at the helm of affairs, representing the 16th Vice Chancellor, and acting in his own capacity as the Deputy Vice Chancellor, Inigo Campus, as well as the chairman of this occasion. Ladies and gentlemen, can we please put our hands together for Professor J.U.J. Onwumere. We have a council member in our midst, Professor Emmanuel Ijeoma. Please come put our hands together for him. It is my delight to recognize the 14th Vice Chancellor of this great institution, Professor Benjamin Ozumba. We have also on the high table the Provost College of Medicine, Professor Hyginus Ezeome. We also have Professor Nene Obianyo. Can we please put our hands together for her? Professor Ike Okwesili. Please put your hands together for him, the Associate Dean, Faculty of Clinical Sciences. I would like to recognize past inaugural lecturers here present, the ones seated over here. In no particular order, we have Venerable Professor Kenechukwu Ilo. Can we please put our hands together for him? Professor Cyril Dim. Please appreciate them. Professor Joy Ebele Ikekbazu. Professor Ngozi Njeze. Professor Chimdi Chuka Okusa. Professor Linda Oge Okoye. Professor Anne Ogbo. Emeritus Venerable Professor Ernest Onwansigwe. Professor Mrs. Chika Onwansigwe. Professor Peter Owad, I can't see this, but let's say Professor Peter Achuku, the middle name I can't see. Professor Anthony Ikefuna. And Oracle Professor J.C. Eze. Prof, it's been a while. Professor F.E. Ejeze. And to the others seated over here, I might not know you all by names, but please, I appreciate you and I recognize you. I think I can see my mommy seated there, the ASU chairman, Director of Maritime Studies, Professor Oraboise Florence. The Deputy Provost College of Medicine, I guess, is over there too. Can we please put our hands together for Professor Kajetan Chigozie Onyedum? And ladies and gentlemen, please put your hands together for every past inaugural lecturer seated in this hall today. Can we please appreciate them specially? All right. On this side of the divide, I did not recognize the representative of the Chairman Senate Ceremonials, who's also acting in his own right as a Secretary of Senate Ceremonials. Please put your hands together for Mr. Obinna Onobia. Ladies and gentlemen, we are gathered here for one reason and one reason alone. My chairman will always say that inaugural lecturer is an academic ofala. Today, to celebrate and to tutor us on a very particular, wonderful, interesting topic is the 245th inaugural lecturer. Ladies and gentlemen, give it all up for Professor Ijeoma Victoria Ezeome. Professor Victoria is not here alone. You can see that, if I am not mistaken, she and her husband, they have a matching academic hoodie. That's to tell you that this love has been a long time coming. But I won't be the one to preempt it. Ladies and gentlemen, if your hands are not too busy, please can you put them together for Professor Emmanuel Rapulochukwu Ezeome, the spouse of our inaugural lecturer. I'd like to briefly recognize the family members of the inaugural lecturer as well as their guests. Although I can see that some are yet to be here, but maybe we'll have to recognize them in absentia. Ladies and gentlemen, can we please put our hands together for Dr. Okuchukwu Tobechukwu Ezeome. I want to believe these are the children. Dr. Chidozie Ifeanyi Chikwu Ezeome. If you're here in this building, give us a wave. You're welcome. You're welcome. Dr. Adeze Chinyere Ezeome. Adeze, are you here? That's nice. Thank you. You're all punctual. Mr. Ugochukwu Ekenediluchukwu Ezeome. Mr. Ugo, are you here? Thank you very much. Miss Ogochukwu Chizoba Ezeome. If you're here, give us a wave as well. You're all welcome. We appreciate you. The siblings of the inaugural lecturer, I'd like us to put our hands together for Mr. Chukwuemeka Anyokora. If I did not pronounce that surname well, pardon me. Mrs. Uchenna Mary Ann Eze, you're welcome. You are so welcome. I can see you from here looking so beautiful. Mrs. Ogochukwu Stella Maris Malagu, please put your hands together for her. Mrs. Blessing Ngozuchukwu Anyakora, Deputy Director, Nursing, UNTH Enugu. Give us a wave. You're welcome, ma'am. I see you. I see you. Thank you for that wonderful smile. Mrs. Gloria Chinwema Enegala, or Enejela. Which of them? I'm sorry. Pardon me. Plus, give us a wave anywhere you are. Thank you. And Mr. Peter Chukwudi Anyakora. Give us a wave. Mr. Maduka Paul Anyakora. You are all welcome. And these are the siblings of the inaugural lecturer. Uncles, cousins, Chief Engineer Jim Okaro, Ezufo na Ogidi. I doubt if he's here yet. So we might have to suspend this for a while later on. Ladies and gentlemen, can we please put our hands together for the CMD UNTH, Professor Obinna Onodugo. Prof, you're welcome. You are very welcome. We see you. We see you, sir. I would like to also quickly recognize special guests of the inaugural lecturer. We'll fall back on the family of the inaugural lecturer later. I doubt if those names are here yet. We have Professor Miki and Chioma Asuzu. Are they here? Please give us a wave if you're here. Professor Miki and Chioma Asuzu. Okay. I think we'll still have to skip this for a while. All right, ladies and gentlemen, without wasting much of our time, permits me to hand the microphone over to the chairman for the chairman's opening remark. If you clap better, I'll do that faster.
Good afternoon, everyone. I'm not going to take much of your time. Let me start by recognizing a council member here present, Professor Emmanuel Ejeome, 14th Vice Chancellor of University of Nigeria, Professor Benjamin Chukwuma Uzumba, the Provost College of Medicine, the Deputy Provost, CMD UNTH, Professor Obinna Onodugo, past inaugural lecturers, professors, great lions and lionesses, ladies and gentlemen. Today we have another Amazon from College of Medicine who will be talking to us today on structural violence and lack of reproductive justice, a state-level ethical failure affecting Nigerian women. Professor Ijeoma Victoria Ezeome. Prof, you're welcome. Violence against women is something many of us abhor. In fact, if you're a man and I happen to hear that you raise your hand on your wife for whatever reason, if you greet me, I won't talk to you. That's for me. Yes. Yes, that's the truth, and it remains the truth. So I don't want to take much of your time. Let me welcome Professor Ijeoma Victoria Ezeome for this inaugural lecture. And I want, on behalf of the 16th Vice Chancellor of this great university, Professor Simon Uchenna Otoanya, declare this inaugural lecture open. Thank you very much.
We are not clapping better. Please put your hands together for the chairman. So officially, this event has been declared open. Before I call on the citation reader, please, ladies and gentlemen, put your hands together for the Honorable Commissioner for Health in Enugu State, Professor George Ugu. You're welcome, Prof. You're very welcome. On that note, I would like to call on Professor, and this must be a very special connection. The Deputy Provost is the one taking the citation reading. Ladies and gentlemen, give it all up for Professor Kajetan Chigozie Onyedum.
Good afternoon, everybody. The Vice Chancellor of the University of Nigeria, ably represented by the Deputy Vice Chancellor Enugu Campus, Professor Ijeoma, Principal Officers of the University, distinguished members of Senate and Council, eminent scholars, ladies and gentlemen, and I add lions and lionesses. Lions and lionesses. It is my privilege and honor to present the citation of the 245th inaugural lecturer of the University of Nigeria, Professor Ijeoma Victoria Ezeome, a distinguished medical doctor, accomplished scholar, bioethicist, mentor, compassionate advocate for the health, dignity, and reproductive rights of women. Professor Ijeoma Ezeome was born 21st July, and we're in July, right? About 60 years ago in Port Harcourt, Pitagua, River State, as the Ada and the second child of Mr. Fidelis Nwekobidigbo Anyakora of Uroji Village and Mrs. Nwajima Victoria Anyakora Nwabeze of Umuru Village, both in Ogidi, in the Demi North local government area of Anambra State. Proudly Ogidi, either way. From an early age, her parents nurtured in her values of discipline, integrity, compassion, and love for learning. These qualities that would later define her features of her personal life and professional journey, as you will hear in this excitation. Her educational journey started at Progressive Primary School, Surulere, Lagos, before she relocated to Ibadan, where she completed her primary school at Methodist School, Okedo. That was due to the transfer of the father to Ibadan at that time. She commenced her secondary education at Prospect High School, Ibadan, before she transferred to the prestigious Federal Government Girls College, Oyo, where she distinguished herself, graduating with 6 distinctions and 3 credits. Life, however, had prepared an important lesson because she didn't gain admission that particular year. She not only missed admission to medicine, but she now went to Lagos at Queen's College, Yaba, Lagos, for higher upper sixth education, and later gained admission to the University of Nigeria the following year to study medicine. This marked the beginning of lifelong commitment to healing, scholarship, and service. She graduated from the Medical School of University of Nigeria in June 1989, the famous 89 class. Have you seen the connection? And did her house job at UNTH Enugu before proceeding to Military Hospital Yaba for her National Youth Service. Determined to specialize in women's health, she passed her primaries in O&G of the West African College of Surgeons, and the same year passed the departmental selection examination in O&G. Unfortunately, there was an embargo on employment on that time, and this commencement of residency had to pause for 3 years, and finally she commenced her residency in 1995. Through perseverance, diligence, and professional excellence, she became a fellow of the West African College of Surgeons in Obstetrics and Gynaecology in 2003. After a brief clinical service at Niger Foundation's hospital in Enugu, she joined the University of Nigeria in 2005 as Lecturer 1 and Honorary Consultant Obstetrician and Gynecologist of the UNTH. Her academic career blossomed steadily through excellence in teaching, research, clinical service, and mentorship, culminating in her promotion to professor in October 2022. In doing so, Professor Ijeoma Ezeome achieved yet another historic milestone as she became the first female professor of Obstetrics and Gynaecology in the UNTH and the first female head of Department of Obs and Gyne, a position she's still holding up to today. When you hear of O&G, you think of only men, but now you can see that there are a lot of women there doing things. Professor Ezeome's scholarship reflects an uncommon ability to combine scientific excellence with deep ethical reflection. Recognizing that women's reproductive health extends beyond clinical intervention alone, she sought specialized training in creating model fertility care system and NAPO technology at Pope John Paul VI Institute for Study of Human Reproduction in Nebraska, United States of America. This expertise enabled her to provide evidence-based fertility care and reproductive health services for women whose personal convictions or medical circumstances made conventional contraception methods unsuitable. Her curiosity did not end here. Through competitive scholarship, she got the Fogati International Center's sponsorship to get a master's degree in bioethics, and this has added to her scholarship in her already distinguished clinical expertise. Today, she serves as a faculty member of the Bioethics Unit of the Institute of Public Health, University of Nigeria, where she coordinates the course on ethics of reproduction and end-of-life care. For more than 2 decades, Professor Ezeome has devoted herself to the care of women battling gynecological cancers. Her research, clinical practice, and international collaborations continue to advance knowledge in cancer prevention, fertility care, reproductive ethics, and women's health. As the current Nigerian representative on the American Society of Clinical Oncology in Sub-Saharan Regional Council, she contributes to initiatives aimed at improving cancer care across Africa and strengthening support for oncology professionals and patients alike. Alongside her clinical practice and research, Professor Ijeoma has remained an exceptional teacher and mentor. She has supervised numerous undergraduate projects, postgraduate dissertations, fellowship theses, and bioethics research, while guiding generations of resident doctors, many of whom themselves are now consultants, professors, and leaders in medicine. So she's a teacher of teachers. Her scholarly publications, conference presentations, and contributions to peer-reviewed journals have earned her respect, both within Nigeria and internationally. Yet, beyond the impressive curriculum vitae, is a woman remembered by her colleagues, students, and patients for her quiet strength, humility, passion, and unwavering commitment to excellence. She exemplifies the rare physician whose intellectual brilliance is matched by empathy, whose scientific rigor is balanced by ethical conviction, and whose leadership is defined not by authority alone, but by service. Behind every successful professional journey is often a supportive family. Professor Ijeoma Victoria Ezeome is happily married to Professor Emmanuel Rapuluchukwu Ezeome, under 89 class, an eminent general surgeon, surgical oncologist, bioethicist of reckoning. Together, they have built a home founded on scholarship, faith, and service, and are blessed with 5 children, which have been introduced. Today's inaugural lecture is therefore much more than an academic tradition. It is the celebration of life devoted to learning, healing, mentoring, and defending the integrity of women through medicine, ethics, and compassionate leadership. Ladies and gentlemen, today we honor not only an accomplished obstetrician and gynecologist, nor only a distinguished bioethicist, researcher, and academic leader. We celebrate a doctor whose life's work has been dedicated to protecting mothers, restoring hope to families, advancing ethical medical practice, and shaping the future of women's healthcare in Nigeria and beyond. Distinguished ladies and gentlemen, it is my profound honor and great privilege that I present to you the 245th inaugural lecturer of the University of Nigeria, Nsukka, Professor Victoria Ijeoma Ezeome.
With a round of applause, can we please make welcome the 245th inaugural lecturer to come give her lecture, Professor Ijeoma Victoria Ezeome. Please keep clapping until she handles the microphone. You're welcome, ma'am.
The Vice Chancellor, Professor Simon Uchenna Otuanya, ably represented by the Deputy Vice Chancellor, University of Nigeria Enugu Campus, Professor J.U.J. Onwumere, and also here in his capacity as DVC Enugu Campus, other DVCs and principal officers of the university, council members. I can see my Professor Emmanuel Ejeome, President of the University of Nigeria Alumni Association, and other officers present, deans of faculties, directors of institutes and centers, heads of departments, distinguished professors, past inaugural lecturers, heads of administrative units, distinguished academics and administrators, priests and reverend sisters here present, Igwes, chiefs and elders, gentlemen of the press, lions and lionesses, ladies and gentlemen. I wish to welcome you all to my inaugural lecture. I thank God for the opportunity of bringing today to fruition, making it possible for you all to be seated here listening to me. My special thanks go to the Vice Chancellor for granting me an opportunity to speak about what I have been doing as an academic for the past 2 decades. I pay tribute to all the 244 inaugural lecturers who paved the way for me and has continued to contribute their own quota to the global discourse of shaping and improving our society. As an adolescent, I grew up observing and cringing at the obvious discriminations, gender biases, and unequal burden faced by the female gender. I remember asking my dad about the customs that kept women down and unable to achieve their full potential. Of course, there were no explanation except for cultural reasons. That is how it is. And I remember announcing to him that it was just a group of men that sat together and decided to make rules at the expense of other people. Frankly, I was afraid, he was afraid I would not get married. But fortunately for him and for me too, I came to UNN and the rest is history. Here I am. During my housemanship at UNTH about 36 years ago, I had no doubt that my subspecialty was definitely going to be O&G, despite my teachers encouraging me to go into pediatrics, community medicine, ophthalmology, because they said that is more feminine, that O&G is a male-dominated field, and that I will come out as being too aggressive. That was the societal expectation. But one wonders why a specialty that looks after women shouldn't be filled with women as specialists. I wish to thank my CMD, Professor Obinna Nodugo, for consistently appointing female OBGYN consultants. He's given us about 4 over the past 3 years. Thank you, sir. Before I dive into the topic of today's lecture, structural violence and lack of reproductive justice, a state-level ethical failure affecting Nigerian women, I wish to appreciate Emeritus Professor Benjamin Chukwuma Uzumba, a professor of professors and the 14th Vice Chancellor of this great university. As Provost of the College of Medicine, he appointed me as the first female lecturer of the Department of O&G. And he was also my supervising consultant during my membership training in O&G UNTH. Thank you, sir. I also wish to appreciate late Professor Arinze Chukwuigwe, the 15th Vice Chancellor of our university, under whose tenure I was elevated to the rank of professor, becoming the first female professor of obstetrics and gynecology, and he also appointed me as the first female HOD of OBGYN UNN. May his soul rest in peace. We'll all agree that women are the bedrock of society. We drive economic growth and family health. Despite this, thousands of us keep losing our lives every year from preventable complications of pregnancy and childbirth, including societally inflicted health challenges. This is a profound human rights and public health crisis. The very high maternal mortality rate of 993 per 100,000 live births as of 2023 reflects existing systemic failures, gender inequities, and a lack of reproductive justice that adversely affect health outcomes for women in Nigeria. Over the next 40 minutes or so, I will explore for my audience the very poor and unacceptable state of health of the Nigerian woman through my worldview as a feminist bioethicist, who is also an obstetrician gynecologist, my lived experiences and research work in general OBGYN, female cancers, infertility, and above all, my experiences as a mother. Throughout this presentation, we are alluding to the key principles of bioethical inquiry, such as, first, respect of persons. When we talk of respect of persons, we mean respecting a person's freedom to choose what is right for them. Hence, we are morally obligated to obtain the consent of autonomous persons to do anything with them or for them, and that consent must be voluntary and fully informed. Then we have the other principle called non-maleficence. It means do no harm, do not cause pain or suffering. As physicians, this is part of the Hippocratic Oath that we take during induction into the medical profession. The full maxim being, first, do no harm. Then we have the principle of beneficence, which goes further than not doing harm, but to actively promote health and alleviate suffering, making all choices for a patient with the intent to benefit him or her. We then have justice, which is fairness in providing treatment to all persons without discrimination. We also have what we call duty of care, which requires one to take reasonable precautions to avoid actions that could foreseeably cause harm. If this duty is breached through negligence, the responsible party requiring one to take reasonable precautions to avoid actions that could foreseeably cause harm. If that duty is breached through negligence, the responsible party, for example, the physician in the case of patients, or the Nigerian government in the case of its citizens, can be held liable for damages. Then we have what we call rights. That's an entitlement owed to one party by another. Rights can be positive and negative. Positive right is someone has the obligation to provide that right to you. These are those rights to refuse treatment and have that refusal respected. So let's dive into maternal mortality. If you look at the screen, you'll see that a woman dies. I don't think it's showing. A woman dies of pregnancy-related causes every 2 minutes. Maternal mortality, according to the World Health Organization, is the death of a woman during pregnancy or within 42 days of the end of pregnancy from causes that are related or aggravated by the pregnancy or its management, excluding unrelated accident or injuries. When we talk about morbidity, it refers to any short or long-term health problems that result from pregnancy and childbirth. Like, for example, when a woman she loses blood, maybe during delivery, and her blood level goes low, that is what we refer to anemia. Anemia is a morbidity. Or when she has obstructed labor, and eventually she has leakage of urine and feces through her vagina, that is what we call morbidity. Nigeria contributes about 29% of all global maternal deaths. And with more than 80,000 women dying every year, Nigeria has missed its target to improve maternal health and women empowerment. Because of poor resource management in the healthcare system, recurrent healthcare workers' industrial action, Boko Haram insurgency in the north, and kidnappings in the south of Nigeria. We know that these conditions have worsened. Therefore, it's not surprising that we keep lagging in the sustainable development goals of maternal good health and well-being, as well as gender equality. This trend depicts the violation of fundamental human rights and a moral failure of the Nigerian society to a section of her membership, the female gender. The major causes of maternal mortality in Nigeria include obstetric hemorrhage, which accounts for about 23% of all maternal deaths in Nigeria. We have sepsis. We also have hypertensive disorders, unsafe abortions, obstructed labor, anemia, and so on. Sadly, these complications are preventable through consistent high-quality antenatal care as well as comprehensive emergency obstetric care. So let's look at obstetric hemorrhage. It's defined as excessive bleeding occurring from about 28 weeks of pregnancy. In lay terms, we call it 7 months. When this bleeding occurs before delivery, we call it antepartum hemorrhage, and it's usually caused by the placenta coming before the baby, or if the placenta is placed normally, but it separates prematurely. When it occurs during childbirth, we call it intrapartum, usually as a result of uterine rupture due to obstructed labor or genital lacerations during that delivery. And when it occurs after childbirth, we call it postpartum, usually as a result of the laxity of the uterus, or maybe there were genital lacerations that were unrecognized and was not repaired. And sometimes there may be placental fragments inside the uterus that was not removed. The commonest obstetric hemorrhage is the postpartum hemorrhage. The unavailability of blood or immediate surgical care is what leads to death from obstetric hemorrhage. Hence, the importance of an emergency obstetric care system. Hypertensive disorders make up 11% of maternal deaths every year. It could be chronic hypertension. In that case, it has been there before the woman got pregnant. Or it could be gestational hypertension where it develops while the woman became pregnant, and most times it may resolve after she delivers. Then we have preeclampsia. In that case, it develops after the woman had become pregnant, maybe about midway into the pregnancy, but there may be associated protein or in the urine, may or may not be, but also the other organs in the body may be affected. Then we have eclampsia where the woman convulses in addition to the high blood pressure. These complications are preventable through consistent, high-quality antenatal care with regular blood pressure measurements and institution of adequate care. A number of these complications from absent or less than ideal care in pregnancy and labor have been highlighted in some of my studies. A 10-year review of neural tube defects in Southeast Nigeria. These neural tube defects are serious birth defects of the brain and spine that occur when the neural tube fails to close completely during the first month of pregnancy. These defects were significantly more common among neonates of unbooked rural women and those who use herbal medications during pregnancy. These birth defects are in the form of gaps in the vertebral column. Sometimes you find fluid-filled sacs with exposed nerves protruding through the baby's back. At other times, you may have underdevelopment of the skull, the scalp, and the main parts of the brain. And rarely, you may have a portion of the brain and the membranes covering it bulged through an opening in the skull. The increased incidence of these defects in these women resulted from their lack of antenatal care, lack of intake of folic acid, and they were also absent at antenatal talks on the dangers of these native medications. We also did a study on asymptomatic bacteriuria in pregnant women in Enugu. Among 430 consenting booked antenatal patients without symptoms of urinary tract infection, we found out that 15.1% had asymptomatic bacteriuria. The attendance of these women for antenatal care enabled the identification of the presence of bacteriuria despite the absence of symptoms, leading to subsequent treatment and avoidance of complications such as acute pyelonephritis, premature rupture of membranes, and increased perinatal morbidity. The importance of antenatal care cannot be overemphasized because it can reduce the health risk of mothers and newborns through monitoring of pregnancies, screening for complications, and educating mothers on healthy nutrition and substances to deliver healthy babies. Let's look at maternal sepsis. Maternal sepsis accounts for 17% of maternal deaths every year. It's a life-threatening condition defined as organ dysfunction from infection during pregnancy or up to 42 days post-delivery. When a woman delivers, her body is open and she's prone to infections. And by the time the infections get into the bloodstream, it might lead to septicemia. Sometimes it can be confused with the normal tiredness that follows delivery. So it's very important that it is recognized early. The condition is aggressive and it escalates very fast. And this is why one cannot overemphasize the import of delivery in a health facility with skilled providers. Delivery at a health facility with skilled providers under hygienic conditions reduces the risk of complications and infections during labor and delivery. If we look at the screen, we will see that, just a minute, let me highlight. You see that 56% of our mothers deliver at home, while only 43% deliver in a health facility. 43% of our women do not receive a postnatal check during the first 2 days after delivery. And it's known that the major driver of maternal sepsis is poor sanitary conditions during home deliveries. In our study on postnatal care services used by mothers in Enugu, we found that 40% of our women do not utilize the 6-week postnatal check, even among those who attended antenatal care. Unfortunately, most maternal deaths occur at this period. Therefore, timely postnatal care provides an opportunity to treat complications arising from delivery, offer intensive care for the newborns, and teach the mother how to care for herself and her newborn, as well as family planning counseling. So let's look at obstructed labor. It accounts for 11% of maternal deaths, and it implies a situation where the descent of the baby through the birth canal is physically blocked despite strong uterine contractions. It usually occurs due to a mismatch between the baby and the birth canal. This occurs commonly with early age of marriage and teenage pregnancy. According to the Nigerian Demographic Health Survey of 2024, 53% of our reproductive age women are already married by 18 years. 15% of our 15 to 19-year-olds have been pregnant at least once, with 11% of them having had at least one live birth. Childbearing at a very young age is associated with an increased risk of complications during pregnancy and childbirth, such as cephalopelvic disproportion, obstructed labor, operative deliveries, and higher rates of maternal and neonatal mortality and morbidity. Therefore, the question is, how can our women become empowered to be able to take personal health decisions if by the age of 18, instead of being in school, they are already mothers under a patriarchal system, unable to negotiate sexual relations? A responsible government will make and enforce laws that will keep children in school, empower them, and ensure they enter marriage because it is their choice. The prolonged obstructed labor can lead to prolonged pressure of the baby's head on the maternal soft tissues. If we look at the screen, you'll find out that the head of the baby is putting pressure, sandwiching the bladder. The head of the baby, the bladder is in between, and anteriorly the pubic bone. And then posteriorly, the head is sandwiching the rectum between the head and the sacral promontory. As a result, it cuts off blood flow and leads to tissue death and formation of holes between the bladder and vagina, or between the rectum and vagina, resulting in long-term urinary and fecal incontinence. It can also put pressure on a nerve we call the obturator nerve and can lead to foot drop. Even the head that is sandwiched on the bones down there can develop swelling called hematoma. It may lead to fetal death eventually. Obstetric fistula has devastating social, economic, and psychological effects. The women are deliberately excluded. You can imagine a woman that is leaking urine. So definitely, sometimes the husbands will send them away. They are shunned, they are banished and abandoned by families. They are unable to work, leading to social isolation, deepening poverty, depression, and vulnerability. The condition reflects global health inequities and failure of the health system to protect the most vulnerable women. So let's look at female genital mutilation. 14% of our women have had their genitals mutilated. Unfortunately, about 7% of them is done by healthcare workers. FGM is not beneficial to health in any form, and it violates the human rights of women and girls. It involves the removal of external female genitalia entirely or in part, along with other injuries to the female genital organs. If you look at the screen, you will see that they use a razor blade. They may cut off what we call the clitoris. Sometimes they will cut off not only just the clitoris, but the inner lips, or cut off everything, the clitoris, the inner lips, and the outer lips, and then they sew it together, leaving only a little hole for the menstrual flow to come out. It's a sexist and societal inflicted cause of obstructed labor, which thrives on the erroneous belief that a woman should be made clean, that it preserves her virginity and purity, and that it improves her marriageability. We all know this is not true. Research has shown that it's even those who have undergone FGM that move around trying to see whether they can feel what they think one feels during sexual intercourse. However, it's primarily based on female subjugation in a male-dominated society. Apart from obstructed labor, FGM can lead to complications such as bleeding, genital infections, scarring of the genitalia, difficult and painful intercourse, infertility, and risk of operative deliveries. Unfortunately, women are often the primary agents who administer and sustain these distressing rituals against other women and girls. They are socialized to believe that these strict behavioral rules are natural and essential to communal living. Most times, the conforming and enforcing of these oppressive norms by older women can be a mechanism to avoid being excluded or shunned themselves, or to gain favor from the dominant group, the male gender. The 1999 Constitution of the Federal Republic of Nigeria, the Violence Against Persons Prohibition Act of 2015, the Child Rights Act, and many state laws prohibit the practice of FGM with penalties stipulated for its performance or engagement of another to perform it. Unfortunately, this has not eradicated this dangerous and degrading procedure because of lack of the consistent enforcement of penalties. So FGM violates the negative rights of women and girls, the right to be left alone and not interfere with one's bodily integrity. Therefore, Nigeria owes the Nigerian woman the obligation to ensure her genitalia is not tampered with, and failure in the enforcement of this obligation is an infringement on her right to life, which is her fundamental human right. The World Health Organization advocates a minimum of 8 antenatal care for favorable experience and good maternal outcome for expectant women. However, according to the Nigerian Demographic Health Survey of 2024, about 40% of women do not have antenatal care at all throughout pregnancy. 50% deliver at home, while only 43% are seen within 2 days of giving birth. All this lead to poor pregnancy outcome and the unacceptably high maternal mortality and morbidity. The reasons are best captured in the 3 delay phases by Thaddeus and Main. If we look at the screen, I'm sorry, those on the high table have no screen to look at. Okay, so we have the decision. The first phase is the decision to seek care. How long it takes the woman to actually decide to seek care. This is at the household level. It involves, it could be that the woman has not been able to even recognize the danger signs. It may be due to financial constraints. She doesn't have money to go about it. Or she may have had a bad experience previously in the healthcare system. And then a lot of times, the women have accepted that they've accepted maternal death. They feel that they've already been pregnant. And so even if they die, it doesn't matter. they have been brainwashed to think that the reason they were giving birth to is so that they can come and deliver. And once they have been pregnant, whether they die in that pregnancy is not a problem. Also, the lack of autonomy, or they have to take permission from family members to seek care. But all in all, it's usually dependent on the low status of women. As a young obstetrician gynecologist, I had a patient who had a previous cesarean section, and when I evaluated her, she lacked the criteria for vaginal birth after cesarean. When I counseled her that she needed cesarean section in this second pregnancy, she refused, and I booked her for elective cesarean section. She never appeared. She went into labor. She stayed back in her home. When she realized that she wasn't delivering, she now came to the hospital. Even at that, she insisted that she must deliver vaginally. When I begged the mother, who was her child caregiver, to please intercede, the woman said that her daughter must deliver vaginally. It was only when the baby developed fetal distress that she agreed, but even then she said, I must go to her husband to sign the consent before I can take her to theater. Of course, if we look at that, she obviously lacked agency. She couldn't express her capacity for intentional action. Her decision to continue laboring was predicated on the societal expectation to deliver vaginally, to earn the name woman. She did not mind dying or her baby dying, provided she was able to meet that cultural expectation. In another study we did on cesarean section on request in a developing country, we found out that most women will opt for vaginal delivery despite a previous cesarean section, because a real woman, they noted, must bear the pains of labor no matter how long it lasts, and subsequently deliver a healthy baby vaginally. These negative cultural beliefs continue to fuel the increasing maternal mortality and morbidity in Nigeria. The second phase of the delay is when, how does the woman get to the facility, identifying and reaching the medical facility. It involves the logistics of getting the woman to an adequately equipped functional healthcare facility. This is hampered by the long distance from where the woman lives to the nearest hospital, lack of affordable transportation, poor roads, lack of a national ambulance service network that will pick the emergency cases to the nearest hospital. We also found that 25% of our women complained of difficulty with accessing care due to the distance to the health center. A good example is a woman in her third pregnancy. She already has 2 living children. She's a known hypertensive, and she was able to deliver her babies vaginally in the healthcare center near her. However, in this third pregnancy, the blood pressure became uncontrolled. She started convulsing. She is now referred to the second level of care. Unfortunately, she doesn't get there until 24 hours. By the time she gets there, she has developed health syndrome, where her organs have been affected by the high blood pressure, which led to her death. This is an avoidable death, had she got to the health facility early. The Nigerian state in this situation failed the woman. It breached its duty of care to that woman because they did not take the precaution of providing transportation in the event of an emergency. Had there been a functional ambulance system to move the woman to the nearest secondary or tertiary facility, she will probably not have died. The third delay is the quality of care the woman receives when she gets to the hospital. We all know that there are shortages of essential supplies, blood transfusion and life-saving medications, inadequate staffing and lack of qualified skilled birth attendants, as well as emergency obstetric personnel. We all know about the Japa syndrome. Our healthcare workers are moving out in droves. Even those who are around are poorly paid, poor motivation for those still around. Medical supplies, including blood and antibiotics, are usually in short supply, despite their importance in emergency obstetric care. The comprehensive emergency obstetric and neonatal care initiatives for indigent women doesn't cover all health centers and is hampered by unavailability of commodities. Take, for example, a Mrs. CO who comes in with ruptured uterus from a maternity. She's already paper white because she had been bleeding. She needs blood transfusion in order for us to stabilize her before she goes in for surgery. In the absence of blood, she dies. This is an unavoidable death. So we asked ourselves, what is comprehensive emergency obstetric care in the absence of essential commodities, including life-saving blood transfusion? Our government needs to do more to prevent avoidable deaths in our women. Let's look at unsafe abortion. Unsafe abortion is the termination of a pregnancy performed by individuals that lack necessary medical skills or in environments that do not meet the minimal medical standards. However, ethicists have argued that the term safe abortion is a misnomer. What is safe about termination of a life? Safe for the mother, but surely not for the baby. However, unsafe abortion results in severe and life-threatening blood loss, dangerous infections from unhygienic conditions, or retained tissues. In Nigeria, abortion remains illegal, but despite this, the world for productive age. Despite the efforts of Society of Gynaecologists and Obstetricians of Nigeria and others, the path to legalizing abortion in the National Assembly remain highly contested. Those who are pro-choice group, they argue that when you force individuals to carry a pregnancy, it is a gross violation of personal autonomy and human rights. They even say that if the fetus has a right to, the fetus has a right to life, that right does not give it a right to use another person's body against their will to survive. They also say that ban on abortion only drives it underground, leading to unsafe, unregulated procedures that endanger lives, and that carrying an unwanted pregnancy or dealing with severe fetal abnormalities or carrying pregnancies that result from rape or sexual assault can cause immense physical and psychological trauma. Those who are pro-life, the pro-life group, as many of us I'm sure are, including myself, we argue that the fetus is a human being with the same moral status and right to life as any born person. Hence, abortion is an intentional ending of an innocent life which is inherently unethical. We also argue that the fetus possesses the potential of personhood, and so it can experience life, and it's morally wrong to deprive it of that future. Also, sexual activity carries the natural biological risk of pregnancy. So when individuals engage in sex, they make deliberate choices and are responsible for the lives they help create. Besides, there are alternatives to abortion, like adoption. Actually, each position has valid claims. However, Nigeria is a multi-religious country where life is seen as sacred, especially that of the unborn. The restricted abortion law is therefore not likely to change soon. The question we should ask is, what programs have the Nigerian government instituted to ensure that women who have unwanted pregnancy deliver safely, since they are not meant to have access to abortion services? The answer is none. That's where the problem is. The Nigerian government should ideally have pregnancy crisis centers within the primary health care system, with a unit in each primary health center to help women manage their unwanted pregnancies so they do not expose themselves to illegal abortion services, leading to maternal death and complications. In Nigeria, only non-governmental organization crisis pregnancy centers exist. Most are faith-based non-profit organizations that offer succor to women faced with unwanted pregnancies. And the lack of regulation by the government has led to criminal elements hiding under some of these centers to run baby selling rackets, exposing young women to kidnapping and slavery. Together with like-minded sisters, have been involved in the care of some of these women in the Happy Home Foundation of Women of Opus Dei in Enugu, as part of our corporate work of apostolate for the past 15 years, in collaboration with the Ministry of Gender Affairs, Enugu. The young girls are admitted to the centers after counseling, sometimes with their parents and guardians, Antenatal care, labor and delivery are usually in Niger Foundation's hospital, and depending on the decision of the women, the baby is either put up for adoption through the Ministry of Gender Affairs, Enugu, and the woman is helped to learn a trade or empowered in some way suited to her circumstance, so she can continue taking care of herself and the baby if she chooses to keep it. In a lecture which I delivered during the Medical Women's Association Enugu 40th anniversary, I noted that most reproductive age females use misoprostol, which is sold as Cytotec. They use it to procure medical termination of unwanted pregnancy. In desperation, these victims swallow many tablets of misoprostol with the aim of evacuating the uterus, falsely believing that it has no side effect. However, while the married woman and those who have some financial capacity present to the hospital for completion and post-abortal care, majority of students and rural dwellers do not. A case scenario called from my practice is a 17-year-old domestic staff who missed her period for 2 months. She took about 5 tablets of Cytotec as advised by an older friend. She develops abdominal cramps, nausea and vomiting with alternating chills and rigors. After about 4 hours of severe abdominal pain, she starts bleeding vaginally, lasting about a week, and then she starts spotting. Eventually, it becomes foul-smelling vaginal discharge, which is chronic. She believes she's been able to remove the pregnancy. A few weeks later, she presents to the emergency room having collapsed while doing her house chores. Evaluation reveals a right-sided ruptured ectopic, which was overlooked because of self-medication. We can imagine what could have resulted. Many have argued that the reason people use illegal means of pregnancy termination is due to the restrictive abortion law. However, many people may still not procure abortion openly, even if abortion were legalized in Nigeria today. This may be because most people do not believe the narrative that the embryo is just a non-living blob of cells. The do not kill injunction is both cultural and religious, and majority of Nigerians adhere to it consciously or unconsciously. The blob of cells is a new life in its earliest stage of existence, as we all were once. So it's the duty of government to ensure that the woman's right to life is preserved by providing alternatives to the illegal abortion clinics that the victims may resort to out of desperation. Women are entitled to appropriate health care as a matter of right. Being citizens of the country, that is what obtains in every civilized nation that has a true government. I would like us to look at the issue of Nigerian women and unpaid care work. Unpaid care is defined as all unpaid services provided within a household for its members, including care of persons, housework, and voluntary community work. These activities are considered work because theoretically, one could pay a third person to perform them. Caregiving is fundamentally moral, holding society together through nurturing and human connection. The ethical tension arises because society praises this nurturing role but takes it for granted and refuses to financially support it. It becomes a case of exploitation and distributive injustice because unpaid care is excluded from the gross domestic product, thereby acting as a massive invisible subsidy to national economies and private households. It's also a case of systemic inequity as women globally perform roughly 3 times more unpaid care work than men, and I think up to 5 times more in Nigeria. It's the duty of female members of the family in Nigeria, particularly in Igbo land, to look after their aged and incapacitated family members. Despite both males and females now work to meet up with family expenses, household duties are often left to the woman alone. In some families, the woman is the breadwinner, and yet she cannot be accorded any privilege, since this will rub off badly on the male ego of her partner. She's still expected to be submissive, to be seen, but not her partner. She's still expected to be submissive, to be seen, but not heard. We continue to cling on to the traditional roles in family dynamics despite the changing society. Women provide care for children and adults in society, most times at the expense of their own health. This may lead to caregiver becoming compassion fatigued, leading to declines in mental and physical health. Care of the elderly by family members is being paid for in some developed nations like the US, even if not as much as standard employment. This will encourage those who are caught up in this work, thereby lifting them out of poverty and dependence on those who work outside the home. Let's now look at the fertility burden of the Nigerian woman. In Nigeria, as happens in other sub-Saharan African countries, a woman is only deserving of the name woman and most importantly, wife when she has been seen to have delivered a child. Within childless marriages, women are likely to be victims of domestic violence and may also endure various forms of emotional and verbal abuse from husband and husband's family members. It's therefore not surprising that women are ready to try anything to have a child, no matter how detrimental it is to their health. They are more likely than fertile women to be exposed to HIV from extramarital attempts to conceive. Women continue bearing an unequal burden of infertility, despite multiple research studies showing that male factors and female factors, it's the fault of the woman. And if pregnancy results in only female children, is the woman that lacks the ability to provide a male heir to continue the family name. In the study we did on seminal fluid features of male partners of infertility patients in Southeast Nigeria, we found that about 41% of 730 semen samples were analyzed had abnormal parameters ranging from abnormal sperm motility, low sperm count, and abnormal morphology. The study concluded that there is a high rate of male factor infertility in this environment, emphasizing the need for evaluation of male partners in every infertility workup. And so I say to our mothers, to our grandmothers, our sisters, and men too, that not all childlessness is the fault of the female partner. A culture that puts the burden of childlessness on the female partner is retrogressive and unfair. In cases where it is due to male factors, the cause remains untreated, while the woman persists in taking all sorts of native concoctions, which lead to complications, infertility itself, and even death. In some families, the woman is encouraged, not in so many words, to go out and get pregnant to hide the male infertility. Her in-laws hound her as if it's her fault that her partner is infertile, framing it that she's wicked and a bad wife if she refuses to do as they expect. Of course, commit adultery and cover male infertility. Unfortunately, women are the enforcers of this unacceptable intragender subjugation, which highlights how deeply ingrained societal expectations compel them to police and control fellow women. Some women are forced to commit adultery to prove to themselves that they are not the ones responsible for the childlessness in the marriage. Fortunately, current availability of DNA tests has made it possible to determine paternity. And when the family finds out that some of the children they've been showing off as theirs does not belong to the family, they shout foul, without taking responsibility for their part in the whole charade. At other times, the couples keep trying for conception, and when the woman gets into perimenopause, the man comes home one day with another woman, who he claims has had a baby for him to confirm that he has always been fertile. The woman may only be telling him what he wants to hear to secure herself a home. In addition, the determinant of gender resides a lot on the male partner. He is the one that has the sex-determining factor that makes the baby a boy or a girl. Unfortunately, the African culture continues to punish women for what is not their fault. So there is no shame in owning up to your infertility, seek treatment, undergo evaluation, and get appropriate treatment, whether you're male or female. So in terms of my areas of research contribution, I've contributed in family planning. Despite the goal of the federal government to increase percentage of women of childbearing age who are actively using or whose partners are using some form of birth control to prevent pregnancy to 27% by 2024, it remains 15% currently, and we're in 2026. So unmet need for family planning consists of all couples who want to space their pregnancies, or they want to totally prevent pregnancies, but they are not using any family planning method. The current unmet need for family planning is 21%. In our study on contraceptive acceptance pattern and trend in UNTH, we found that intrauterine contraceptive device was the commonest family planning method, followed by implants and then injectables. However, according to the 2024 Nigerian Demographic Health Survey, 12-month discontinuation rates remain high at 30 to 50% for pills, condoms, and injectables, and 5 to 15% for IUCDs and implants. We also did a study on the knowledge and use of fertility awareness-based methods of family planning, among men and women in Enugu. We found that 70% of our respondents had never used the standard contraception due to the fear of side effects, religious reasons, and disapproval by the spouse, whereas greater than 60% of them had no awareness of the newer effective fertility awareness-based methods. It became imperative that we needed to put in more effort to make these fertility awareness-based methods available to our women. And to address this problem, I devoted a good proportion of my work and research on newer fertility awareness approaches to family planning. Following my training as a fertility care practitioner of creating model system, I've taught numerous couples to appreciate their fertility. This system is built on an advanced educational technology. Couples are taught to take care of their fertility and are given responsible parenthood instructions for achieving and avoiding pregnancy, timing conception, pregnancy evaluation. They can protract their procreative cycle and also marital bonding. The system has multiple advantages, such as being a shared system between the couples, is of proven reliability with multiple studies to back its effectiveness. It's comparatively inexpensive, is natural and cooperative, it's medically safe, respects the dignity of women and marriage, and has a standardized research foundation. If you look at the screen, for those who can see the screen, you can see the back of the chart and then the inside of the chart. And when the woman starts charting, the chart will look like this. This is the bleeding, the dry days, the mucus production, and then another dryness before the next periods come. In a pilot study of this system of natural family planning in a subpopulation of men in Enugu, we found that the clients using the system switched to it as a result of excessive and irregular uterine bleeding from their use of hormonal contraception and intrauterine contraceptive device. The disadvantage of the system were identified as the high degree of motivation and discipline required of the couples and avoidance of genital contact during the woman's fertile period. None of those using the system to limit pregnancy ever got pregnant. But for those who were using it to space pregnancy, they only got pregnant when they wanted to. A significant number of women continue to choose to use the family awareness-based methods with support from their spouses, and in accordance with human rights principles, people should have access to the widest range of contraceptive methods, preferences, and their changing needs throughout their reproductive lives. In a study we did on knowledge and attitude among Nigerian gynecologists about fertility awareness-based contraception, we found that a lot of our gynecologists were still using the ineffective calendar rhythm method. They had a lot of misconceptions and ignorance about the effectiveness of the newly fertility awareness-based methods. And so it's important that they update their knowledge on the newer effective method, thus improving women's access to these methods in fulfillment of their family planning choices. As a NAPRO technology medical consultant from the Paul VI Institute for the Study of Human Reproduction, I've managed my clients for a wide range of conditions through this new reproductive science, which cooperates with the menstrual and fertility cycles. It unites procreation, medical technology, and it has multiple applications. These are things I planning, target hormonal evaluation, hormone replacement, as well as infertility. Usually it starts with the Creating Model Fertility Care System, where the woman will chart her biomarkers to pinpoint exact times of fertility and identify abnormalities in the post-ovulatory hormone phase. If you look at the screen, you will see that the woman, there are 4 charts here. The woman bled for about 6 days, followed by dryness, but there was only a single day of mucus production before she became all through dry. This is what you see in infertility. And so this woman has very limited mucus. An evaluation will be to find out why she has such. And the second one, you can see that after the peak day, when you have ovulated, the post-peak phase is only 5 days, whereas therefore, this woman will be prone to miscarriages, and unless it is corrected before she gets pregnant again, she's likely to miscarry. Infertility is one of the applications of NAPRO technology, and in most cases, the infertility is a symptom of underlying problems causing difficulty in conceiving and miscarriages. NAPRO technology involves a staircase approach to evaluation of infertility. It consists of charting one's menstrual cycle, evaluation of the reproductive hormones, treating the organic diseases identified, and then treating cycle by cycle of hormones and target organ dysfunction. And if it's unsuccessful, adoption is offered. So NAPRO technology should be promoted and widely endorsed by the medical and scientific. Is less risky, is less expensive, and it protects the physical and spiritual unity of the conjugal act. If we look at assisted reproductive technology, many couples who can afford the treatment have started making use of it to solve their problem of childlessness. It has revolutionized infertility treatment, giving couples their own genetic children with a cumulative average delivery rate of about 31%. However, it's heavily based on the woman's age, the clinic expertise, and the patient's specific medical factors. It's also been found to be fraught with many ethical and legal challenges. ART encompasses all treatments and procedures that involve handling the eggs, the sperm, and embryo outside of the body of the woman to establish a pregnancy. The commonest is IVF. However, some ethicists have insisted that ART is unethical due to its lack of holistic management of the woman for infertility. It says that ART does not necessarily cure the conditions causing the infertility. It primarily manages the reproductive system rather than addressing the physical, emotional, and lifestyle root causes of the woman's health. In our study on experiences of female clients in the assisted reproductive technology process in Nigeria, we found that women suffer a high level of anxiety and fear during their assisted conception process, and only those who have gone through it can imagine what they go through when they have a failed cycle. In my MSc Bioethics dissertation on perception of key ethical issues in assisted reproductive technology by providers and clients in Nigeria, we found that the cost of this technology is exorbitant. Majority of the ART centers are private sector driven, though there are a few public tertiary health establishments that have started giving the service. Payment for services in Nigeria is out of pocket. The high cost of the facilities is one of the reasons female clients present at advanced age, thereby reducing the success rate of the procedure. ART provides an excellent example of stratified reproduction. The global elites have access, leaving infertile poor unable to afford it due to the high cost. The National Health Insurance does not cover routine infertility treatment, not to mention assisted conception services. However, considering that procreation and parenting are of such central importance to an individual's identity and life goals, medical insurance should pay for infertility treatment. Achieving full reproductive rights of accessing care to aid fertility is a positive right to which all women are entitled to and should be provided by the Nigerian state. The participating clients in our study also confirmed that the centers they assessed for IVF transfer 5 embryos as a matter of protocol, This is contrary to the Association for Fertility and Reproductive Health guideline, which recommends a maximum of 3. This has ethical implications because there will be a high risk of higher order multiple pregnancies with its attendant complications of maternal and fetal morbidity and mortality. Facilities for fetal reduction in Nigeria is lacking, and even in centers where it may be present, any attempt at this is seen as abortion and is greatly frowned out. Such willful actions of practitioners to maximize output of their procedures are in violations of the ethical principles of non-maleficence and beneficence. While the guideline instituted by the Association for Fertility and Reproductive Health for its members is a welcome development, the lack of legal enforcement continues to expose ART clients to the risk of inappropriate practice by providers. Viewed from the lens of feminist bioethics, approaches to new reproductive technologies, women bear a disproportionate share of the associated risks and burdens within these assisted reproductive technologies. That is to say, ART is not gender neutral, a fact that is frequently ignored in debates about the ethics of assisted reproduction. The Association of Reproductive Health guideline is not binding on all practitioners except for those who are members of the association. So the Nigerian government ought to expedite the passage of the ART bill, which has been in the House of Assembly since 2012, as well as enforce its content to avoid the exposure of ART clients to the risk of inappropriate practice by providers and fraudsters. Both ART and NAPRO technology should be financed by the federal government to enable couples dealing with childlessness achieve their reproductive wishes as a component of their reproductive health and rights. I must say that while the new reproductive technologies have brought about key recognizable advances in management of many disease conditions, so also has it brought forth myriads of ethical dilemmas. However, there is need to continually review technologies through the prism of biomedical ethics to ensure that it withstands the principles of autonomy, beneficence, non-maleficence, and justice. Many people experience a very natural urge to be parents. Some are seeking to satisfy this urge using reproductive technology without understanding all their implications. Before using technological methods of reproduction, it's wise to study in depth the available options. Now let's look at cervical cancer. It's caused mainly by human papilloma virus and is the second commonest cause of female cancer deaths in Nigeria. This cancer is totally preventable and is one of the cancers that has a recognizable pre-invasive stage. The pre-invasive conditions are primarily identified through routine screening, which allows for timely intervention to prevent the development of invasive cancer. We found out that risky sexual behavior like multiple sexual partners or male partners that have multiple partners, as well as early age of sexual intercourse and early age at first full pregnancy are linked to a higher risk of developing cervical cancer. The Nigerian Demographic Health Survey shows that 53% of our women aged 25 to 49 years, they've had their first intercourse by the age of 18, and 15% of them at the age of 15 years. The average age of first full pregnancy is 18 years in our country, and 29% of our women are in polygamous unions. These statistics expose Nigerian women to a dire risk of HPV infection, fueled by the added underutilization of preventive measures. Other risk factors are immunosuppressions with HIV/AIDS or other causes of immunosuppression. Our study on gynecological cancers in HIV-positive and negative women in UNTH found that HIV-positive clients present at a much earlier age with more advanced disease, mostly cervical cancer of the squamous cell variety. We also did a study on complementary and alternative medicine use among gynecological cancer patients in Enugu, and we've established that their use is high in Enugu, which contributes to delays in their presentation for orthodox care. Several strategies have been recommended by the World Health Organization to prevent HPV infections and identify precancerous cervical lesions. And these include education and awareness, regular cervical screening of sexually active females, and introduction of an effective and affordable HPV vaccination program. in our study on knowledge, attitude, desire, and practice of vaccination against human papillomavirus in adolescent girls by mothers in Nigeria, we found that the mothers' high intention to vaccinate did not match the low uptake of vaccination due to concerns for early sexual debut of their daughters. We also know that men are the primary decision makers about family life, including healthcare in Nigeria. And to make decisions that impact positively on their families, it's important that men should have adequate knowledge about causation and preventive measures to curb the cervical cancer scourge. We therefore studied male acceptance of human papilloma vaccine for family members in Enugu, where we found that majority will accept vaccination for their wives, but very few for their children, with less than 10% accepting son vaccination. This may be related to misconceptions about the effect of the vaccines on male sexuality, and this emphasizes the importance of reproductive health programs for education of men on HPV infection and their role as family decision makers in prevention of disease. Unfortunately, Nigeria's cervical cancer elimination programs have yet to adequately address the screening and treatment strategies. HPV testing is not yet available in our health centers, despite being the preferable method of cervical screening for eligible women in Nigeria. The extremely low rates of pap smears and HPV vaccination hesitancy allow early precancerous changes to go undetected and progress into invasive disease. And in addition, the screening at the different health institutions remain opportunistic. Nigeria is lagging on the WHO global strategy for elimination of cervical cancer targets by 2030. In Nigeria, we have only 12 million girls having been vaccinated out of 31 million. A primary health care integrative structured program close to the dwellings of the women is the approach that will best serve the Nigerian populace and make significant progress in increasing screening rates. Women should take advantage of whatever screening method is available. With pap smear, for the general population, every woman from the age of 30 should undergo screening every 3 years and stop at 65 years. And those who have HIV should start screening at about 25 years. They should screen 3 yearly and stop at 65 years. And if they are using the HPV DNA testing, for the general population, they should start at 30 years, screen every 5 to 10 years, and stop at 65 years. And those who have HIV or immunosuppression should start earlier at 25 years, screen every 3 to 5 years, and stop at 65 years. So it remains to be seen if the primary healthcare integration of cancer screening becomes a reality, because no woman should present late for treatment if there is a sincere political will on the part of the government to curb this deadly and but preventable condition. So let's look at what recommendations are we giving. While there is no enforceable right to health in the 1999 Constitution, the right to life is guaranteed in Section 33 of the Nigerian Constitution, and preventable maternal mortality represents a violation of a woman's right to life. So Nigeria needs to increase its allocation to maternal health by ensuring the following: integration of maternal health services such as antenatal, labor, delivery, and postnatal, including prevention of female cancers, into primary healthcare system. Sustainable, comprehensive emergency obstetric and neonatal care accessible to the mothers, no matter how remote their dwelling may be, with a dedicated ambulance service should there be need for transfer to secondary or tertiary level of care. Protection and empowerment of women, starting from the girl child, by enforcing the laws against FGM, while educating the practitioners as well as the parents of the negative consequences of such procedures. Government can also introduce into the national school curricula teaching of healthy communication, emotional intelligence, and critical thinking regarding traditional stereotypes, so as to uproot internalized prejudices against women and girls before it can be normalized into adulthood. Civil society can also facilitate workshops that encourage women to reflect on their own behaviors and the potential impact they have on other women, directly challenging the assumption that women should compete for male validation or rigidly enforce patriarchal cultural practices. Mothers could also help by teaching equality in chores for both boys and girls, model mutual respect at home, and reject all double standards by teaching boys and girls the exact same values regarding consent, polite language, and personal boundaries so that they can learn that women deserve to be valued and respected. Presentation of evidence of wellness checks like pap smears, mammography, prostate-specific antigen, and so on can be incorporated into primary and secondary school enrollment to encourage parents to take advantage of these services for a healthier society and ultimately national economic progress. There should also be provision of all scientific family planning methods, including fertility awareness-based methods, with training of the needed manpower to ensure all women can truly make a choice. And the government should provide subsidized specialized fertility treatment of choice as part of the National Health Insurance Scheme for couples as needed to help them enjoy parenthood. The immediate passage of ART bill that has been in the National Assembly since 2012 to protect our vulnerable infertile women and prevent exploitation or mistreatment. And also, if the government truly believes that the anti-abortion laws are made for the good of the nation, then they should provide and regulate crisis pregnancy centers across the nation to support and discourage pregnant women from procuring illegal abortion, which is endangering their lives with increasing maternal morbidity and mortality. The issue of Nigerian women's unpaid care work should be addressed as it contributes to physical strain from prolonged domestic labor, mental health stress from continuous caregiving without support, and limited time for self-care and healthcare access. Unpaid care work should be recognized and paid for by the government, as it remains an important contribution to healthcare and national economy. So to conclude, systemic causes of shortages of skilled health workers, reliance on foreign aid, inadequate infrastructures, unreliable referral systems with sociocultural barriers such as gender inequality, and the low value placed on women's reproductive health, including financial barriers, all work together to keep the maternal mortality at the current alarming rate. The state of the Nigerian women's health is intimately linked to the limited decision-making capacity of women, which derives from the sociocultural barriers the society places on women. In addition, the failure by state systems to provide life-saving obstetric care constitutes an ethical and legal breach of the woman's inalienable right to life and bodily integrity, and the government should be held accountable. Governmental failure to guarantee reproductive justice is compounded by a refusal to fully implement international human rights obligations despite being signatory to multiple international treaties. Failure to domesticate these treaties into national law renders them unenforceable in Nigerian courts, leaving women exposed to harmful traditional practices, sexual and gender-based violence which thrive in our deeply patriarchal society, leaving survivors without proper legal or medical outreach. There is need for government to wake up to its duty to the Nigerian woman by providing a comprehensive health framework which covers the woman's health in a holistic manner from girlhood through pregnancy and well into menopause. So it's not enough to pay lip service to the plight of women. The Nigerian government must stop contributing to the oppression of women by fulfilling their duty of care towards them. And to address this crisis from a bioethical perspective, urgent action is needed on equitable resource distribution, enhancing the autonomy of women in decision-making, and strengthening the accountability of the health system to ensure the right to life. So I wish to thank my husband and best friend, Professor Emmanuel Rapuchukwu Ezeome. He ensured I put together this inaugural lecture, And as soon as I was elevated to the rank of professor, he reminded me of this lecture. And for those who know him, he's a well-organized perfectionist. You are what I asked God for in a man and more, and I have no regrets at all for the past 3 decades of our marriage. Thank you so much for all your love and support, and for remaining the simple person I wedded. And to my children, Dr. Okuchukwu, he's a resident in public health at UCH Ibadan. I'm sure he's online. Chidozie, who is currently serving his youth service at 103 Battalion Gariki. Dr. Adeze, who is doing her housemanship at National Hospital Abuja. Ugochukwu, he's a final year of electronic engineering, UNN. And Ogochukwu, she's a qualified chartered accountant and 3rd year economic student at Pan Atlantic University, Lagos. She's also online. I thank you all for the opportunity and joy of motherhood that you all keep giving me. As you make your way through the hurdles of life, I pray that God continues to perfect his will in your lives. Amen. To my late dad, Fidelis Nweke Obi Dibwanya Kora, who transitioned to be with our Lord 11 years ago, I say a big thank you for all you did for me, ensuring I went through the university despite your early retirement from UAC due to the structural adjustment program of the 1980s. You visited me at Nsukka every 3 months in that your Toyota, all the way from Lagos. And you continued even at Lady Ibiam. Once he comes, everybody will call me that your father is here. You took me to Ibadan personally for my primaries in ONG, and we were looking for accommodation. It was so funny because I was the only person being followed around by her father. I really wish you are here to witness today, but God knows best. May your soul continue to rest in peace. To my mother, Mwajima Victoria Anyakora, a beautiful woman, inside and out, I say a big thank you for all your sacrifices and nurturing. I remember how you sold your wrappers and belongings to feed us and ensure we did not lack, while my dad was at the war front fighting the Nigerian Biafran War. Despite your health challenges, you remain a happy woman surrounded by your 9 children and their families. May God continue to bless and reward you for all your labor of love, granting you many more years of good health. To my maternal grandmother, Ijeoma Nwabeze, alias Nnedi Beze, with whom I lived throughout my university education at Umuru Ogidi, because my parents lived in Lagos and our holidays in medical school was very short. I thank you for teaching me to live simply, close to nature. Together we used to go to the farm to collect firewood and make ogili, both for use and sale. May your soul continue to rest in peace. And to my brothers and sisters, Chukwuemeka Anyakora, if he's here, he should wave. My Uchenna, Mary Ann Eze, Ogochukwu Malagu, Blessing Ugochukwu, Gloria Enegela, I'm sure she's online, she couldn't come. Joshua Anyakora, Peter and Maduka, I'm sure they are all online. Growing up with you have been enjoyable, filled with beautiful memories of our exploits as we navigated the different stages of our lives. May God continue to fulfill you in all your endeavors. To my in-laws, Mrs. Chizoba Anyakora, Engineer Mwife Obieze, Engineer Dominic Malagu, Engineer Pius Ugochukwu, Dr. Joseph Enegela, and Mrs. Tosin Anyakora. You have all been a blessing to the family of Fidelis Obi Dibo Anyakora, bringing your positive influences on the family. I thank you all. And to my 95-year-old mother-in-law, Mary Ezeome Izukwuwanyi, I thank you for raising my husband as a man of strong character. I tap into your longevity in good health with you sweeping around the compound, may God continue to grant you good health as you reap the fruits of your labor. And to my sister-in-law, Professor Agnes Anarado, I'm sure she's here, I say a big thank you for all the support you gave my husband during his medical school training and being a big sister to me for the past 3 decades. May God continue to bless you and keep you healthy as you continue to give your best as the provost of the College of Nursing Sciences, UNTH, despite having retired from the University of Nigeria, even as you reap the fruits of your labor in your children and your mentees. To my mentor, late Professor Gabriel Ilabache, an obstetrician gynecologist par excellence, who was the first person to encourage me on the quest to specialize in ONG at a time when OBGYN was seen as a male-dominated subspecialty. He taught me most of the surgical skills I have. He's not physically present now, but I'm sure he saw it in the horizon before he transitioned to glory. Thank you, sir. I think his wife should be around here. Barrister Mrs. Irene Ilabache. Thank you, ma. Also to a dear colleague and former roommate in medical school, late Dr. Stella Tabansi. We were the only 2 female residents in ONG UNTH in 1995. She was a very skilled surgeon. Her confidence was infectious, which strengthened mine as we navigated the rigorous training as budding obstetrician gynecologists. May her soul continue to rest in peace. Amen. I also wish to thank late Dr. Chukwu Ibezim, who was the only OBGYN representative at my wedding in Ibadan in 1997. He ensured I ate well, using his personal money to buy food during our labor ward calls then, together, giving up the residence call room at UNTH old site for me to rest, despite being my senior. May his soul rest in peace. I also know that the wife is somewhere here, Mrs. Chebonam Chukwu. Okay, thank you, ma. She's the director of Ibezim Clinics, Enugu. Many of you seated here or online contributed to shaping me professionally as my teachers and colleagues. I wish to say a big thank you to my seniors, peers, and junior colleagues who in one way or the other supported me through residency and clinical practice. Professors Miki and Chioma Asuzu, whose influences in the life of my husband and I have been immense. Late Dr. John Okaro, late Dr. P.C. Nweke, Professor A.C.C. Ikeme, Professor Obioma Okezie, Professor Anyebue Uzochukwu, late Dr. Guano Young Prof, Professor Emmanuel Obikili, Professor Hyacinth Ona, Professor Samuel Obi, Professor Justus Eze, Professor Frank Ezugu, Professor Ikako Lawrence, Professor Peter Nkwo, Professor Tochukwu Okeke, Professor Chibuike Chibu, Professor Theophilus Wankwo, Professor Leonard Aja, and Professor Uche Anthony Ume. I also wish to appreciate my classmates of Federal Government Girls College on Winnie Hill, Oyo. I remember that's me sitting to the left of the teacher. That's how I used to look like then. I wish to appreciate them. I remember how we navigated the last days of our WAEC exams with our no-nonsense, spared the rod and spoiled the child principal, late Mrs. Durodola. May her soul rest in peace. I'm proud to have had the opportunity of growing up with you all. May God continue to lead us in all our endeavors. I also wish to thank my 1989 medical class, the great 1989 class. Those who are here in UNN, they can attest to how great we are. I'm very proud to have been a part of these great minds, making lasting impacts in all the environments they are in. Professor Uzo Ezeome, Provost, College of Medicine, UNN. Professor Kajetan Onyedum, Deputy Provost, College of Medicine, UNN. Professor Chukwuemeka Ioke, Deputy Provost, College of Postgraduate Studies, Enugu Campus. Professor Uche Nwara, former Provost, College of Medicine, UNN. former Dean, Faculty of Clinical Sciences, Professor Adara Aji, Professor Emmanuel Agowa, Professor Boniface Eze, Professor Gerald Udigwe, former Provost, College of Medicine, Nnamdi Azikiwe University, Professor Chibu Bright, Professor Cyril Ezenyaku, Dan Onwusolo, Professor Rosemary Nwolisa Uguneli, Dr. Olunwa Ipazu, Dr. Rosemary Oredu, Dr. Ngozi Chukwuemeka, Dr. Obianuju Okam Ubanwa, Dr. Leslie Adibe Akosa, Dr. Ifeoma Chinwuba Iwuchukwu, Dr. Ngozi Johnson Obuneke, Dr. Ifeoma Ifekandu Okocha, and many others, too numerous to mention. May God continue to guide us as we meet the needs of our patients. I wish to appreciate my teachers during my training as fertility care practitioner and natural family planning medical consultant at the Popol 6 Institute for the Study of Human Reproduction in Omaha. If you look at the screen, this is myself here, Chioma Obodo, for those of us who know her, and this is Dr. Ezeome. Also, when we did the natural family planning medical consultant training, here I am, Ezeome, Chioma Obodo, and Ezeome. So my teachers are Professor Thomas Hilgers, Dr. Henrietta Williams, Dr. Wanda Ali Balogun, Dr. Francis Achebe, Margaret Howard, and Margaret Neal. Many thanks to my mentors, teachers, and supervisors during my training as a bioethicist in the Department of Bioethics, University of Ibadan, Dr. Clement Adebamowo, an accomplished professor of surgery and epidemiologist who introduced bioethics to University of Ibadan and subsequently all over the country, as well as training of research ethics committees. It was under his NIH study grant that I was fortunate to undergo my MSc in bioethics, and it was also that grant that was used to fund the bioethics unit, UNN, before it now got its own grant 5 years ago. The head of department, Professor Temidayo Ogundiran, Professor Samuel Ayodele Jegede, who not only taught me the rudiments of bioethics, but continues to mentor and collaborate with me in multiple studies. Professor Simisola Akintola, who supervised my dissertation, and all my teachers, Professor Ademola Ajumo, Adebayo Adejumo, Agulanna, Bolatito Lanre Abbas, Ikeoluwakwa Ajayi, Olayinka Eyelade, Akin Odebumi, Babatunde Omobowale, Ademalomo, and Doctors Ayo Shisowo and Lokulo Shodipe. And also my fellow students, Dr. Ibijoke Ehimowo, Adodan Ladi, Isaac Adedeji, Shola Alukarowolo, Wumi, and the program administrator, Olusegun Adeyemo. Well, I also have to say very big thanks to the OBGYN consultants and residents for your support for the past 3 years as HOD. Dr. Ilo Alo Emeka, Dr. Ekwazi Kingsley, Professor Asimadu Eric, Professor Valubu, Professor Zugu Eusebus, Professor Cyril Dean, our own Commissioner for Health, Professor George Ubu, Assured Professor Agu Polycarp, Dr. Obioha Episteme, Dr. Duko Nyabochukwu, Associate Professor Ezugore, Dr. Asogwa Augustine, Dr. Ifeoma Njoko, Dr. Udalo Peter, Associate Professor Izuka Emmanuel, Dr. Okoro Silas, Medumba Ifani, Uban Namdi, Nnaji Henry, Godwin Odo, Augustine Olibe, Innocent Omeje, Chidike Ezewi, and the Chief Resident, Dr. Augustine Agora, representing all OBGYN residents. We've all been working together as one happy family, making each other better and ensuring our department keeps moving forward. To my sisters and brothers in Opus Dei, I thank you all for your help as we struggle to live lives worthy of our Lord Jesus Christ and our founder, Saint Josemaria Escriva de Balagwe, sanctifying our professional and daily lives. May we continue to light up all the ways of the earth with the fire of Christ that we carry in our hearts. and to my LOC and committee of friends who have toiled for the past 4 weeks to ensure that today is hitch-free with a successful inaugural lecture. May God meet you all at the point of your need and grant you all your heart desires. Professor Leonard Aja, Dr. Vincent Enemo, Professor Chukwuemeka Iyoke, Dr. Duru Chinazo Victor, Dr. Emmanuel Aneke, Associate Professor Onwuka, Pharmacist Uju Anyebosi, Dr. Elijah Onwudiwe, Dr. Chioma Emegako, Dr. John Paul Nnabo, Chidebere Ifebi, Michael Eze, Cyril Obonna, Ezeamaka Ezenkwele, Pharmacist Chinelo Zumba, Dr. Jude Akabeze, Dr. Kingsley Ekwazo, Dr. Ifeanyi Achara, Ifeoma Edegwara, Tochukwu Ifezuoke, Chinyere Moloku, Ugunna Nwachukwu, Christian Okafo, Professor Reverend Mr. Anene Jekwu, Dr. Ike Okwesili, Pharmacist Ogo Onwujekwe, Mrs. Celestina Chime, Mrs. Ifeoma Onyene, Pharmacist Ndubisi Onya, Mr. Augustine Woye, and ADN Eunice Oba. And finally, to our Lord who made this day possible, may his name be praised forever and ever. Amen. Thank you.
With a standing ovation and a round of applause, can we please give it all up for Prophet? Please clapping, keep clapping until she sits down. Appreciates the 245th inaugural lecturer, Professor Ijeoma Victoria Ezeome. I don't need to ask if it was a fantastic lecture because I enjoyed it. Did you enjoy the lecture? But I guess the women enjoyed the lecture more, right? Because when it was time to clap, I could notice that the men were like, what is she saying? And I also noticed the 14th Vice Chancellor, he would just steal a glance at her and smile and be like, I understand what you're saying, but you know. But then the chairman was all up for it. He was just appreciating and clapping and clapping. Ladies and gentlemen, please put your hands together for the lecturer. Women go through a lot in Nigeria. A certain man in Delta State named Mr. Ejiro got married to his wife and he gave him 5 girls. He got angry and chased her away. Meanwhile, he's a civil servant and the wife was a nurse. He got the second woman. The woman came in and gave him 4 daughters, making it how many girls now? 9 girls. He was pissed. He had a concubine and that one gave him triplets, all girls. Guess what Mr. Ejiro did? He ended up using a 14-seater bus to convey his children to school by himself. He became the maid guard in his house by himself because he who has gotten himself an ant-infested firewood must do what? Every day, boys loiter around his compound and Mr. Ejiro never had peace. And this is a true life story. So ladies and gentlemen, you have learned today that if a man does not have daughters, it is not the woman's, it does not have a male son, sorry, it is not the woman's fault. Don't be like Mr. Ejiro. I'd like to quickly recognize Reverend Father Dr. Benjamin Eze. If you're here, just give us a wave. We would have done this earlier, but you were not here at the time. Father Luis Okpoko, Assistant Parish Priest. All those people are from Maria Rosa Miss Independence Layout. Reverend Father Emmanuel Olayinka your day. If you're here, please give us a wave. Can we still appreciate them? Because I see people on white. Reverend Father Callistus Ezeome, Secretary to the Auxiliary Bishop, Diocese of Enugu. If you're here, sir, please give us a wave. Reverend Sister Dr. Mary Jane Patrick Okolie, DMM, Senior Lecturer, Department of English and Literary Studies. If you're here, please give us a wave, ma'am. You're welcome. Reverend Sister Ansila Kate Umobieri, Associate Professor, UNN, and Consultant Community Medicine, UNTH Enugu. Please give us a wave quickly. Reverend Father Dr. Frederick Oriegbu, Priest of Opus Dei. Please give us a wave if you're here. Please appreciate them regardless. Reverend Father Francis Arinze Ude, Chaplain, Christ the King Chaplaincy, Federal College of Education, Technical, Umunze, Anambra State. Sir, if you're here, give us a wave. Thank you very much. Oh, you're welcome. We'll see you, sir. Thank you. Thank you. Quickly, we'll recognize a special guest for the in-laws and cousins and family members of the inaugural lecturer and the spouse. You're duly recognized. We appreciate you. We might not be doing that again, but we appreciate you. Please appreciate them especially with a round of applause. And quickly, I want to recognize special guest, Professor Miki Anchoma Asuzu, Barrister Mrs. Irene Iloabachie, Mrs. Bonam Chuku. Appreciate them and just give us a wave when you hear your name. We're running out of Basim Clinics Enugu, African Women Lawyers Association Enugu chapter. If they are here, just appreciate them. Barrister Chidi Grace Obeke, State Coordinator. Barrister Uju Owefi, you're welcome. Barrister Sylvia Abana, you're welcome. Barrister Georgina Emeribe and Barrister Mma Ogbonna. Please appreciate them specially. You're all welcome. We also want to recognize Professor Robinson Ono, CMD, Alex Ekweme Federal University Teaching Hospital. If you're here, please give us a wave. Ebonyi State, all the way from Ebonyi State. Thank you. We'd like to also recognize Barrister Mrs. Dimpna Zani, Professor Regina Ayer, Professor Mabel Apwaka, Ijeoma Justina Ofia, SAN. Please put your hands together for them. Or if you're here, just give us a wave. Honorable Justice Linda Okibe, Honorable Justice Angela Anidi, please appreciate them specially. Barrister Waneka Okolo, Honorable Justice Irene Ndigwe, if you're here, appreciate them, give us a wave. Barrister Pat Ofili, Mrs. Vivian, Mrs. Regina Emelu, Kechinwane, we appreciate you all very specially. And is Chief Joseph is that Oswaku 1 of Nise. Sir, please pardon me. And I cannot see this particular name, so we'll take that later. Right about now, permits me to hand the microphone over to the chairman for the post-chairman's lecture comments. Can we please put our hands together for him?
Thank you, ladies and gentlemen. Let me also stand up. Already established protocols. The inaugural lecturer, Professor Ijeoma Ezeome, has delivered a wonderful lecture. I will say, let me start by saying, we give her 6 hoorays. When I say hip hip hip, you say hooray. This is time. Hip hip hip. Hooray! 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 I think the College of Medicine has been so. The Amazons from that college have been wonderful. This is a woman of many firsts, and she has ventured into areas dominated by men. And I know many jealous men like more women to venture into this area. Is it not true? Because many men who want their wives to be seen, jealous ones, very jealous ones, to be seen by their fellow men. Yes, that's the truth. That's the truth. So we want more women in this area. And for you, I would say, College of Nurses is proud of you. The university is very proud of you. Of course, is proud of you. We want more women to go into this area. Because we talked about so many things to discuss with the clash of modernity and tradition. Negative aspects of tradition, because I know that there are positive aspects. So today I'm very happy, and we've learned a lot. So much. We learned a lot. Thank you so much. And at least I heard of NAPRO technology and assisted reproductive technology. There is a bill before the House of Rep, which is a system that should be passed as urgently as possible. So, on behalf of the university, on behalf of my iconic Vice Chancellor, Professor Simon Uchenna Otuanya, congratulations once again. May you live long for us, and may you mentor as many females as possible, including men. Thank you very much, ma'am. On behalf of University of Nigeria, through our Vice Chancellor, Professor Simon Uchenna Otuanya, I present this plaque to you as the 245th inaugural lecturer of our great university, given this day, Thursday, 9th July, 2026. Congratulations. Yeah, as usual, the university recognizes that you have friends, relations, and well-wishers you would like to give, who would like to have copies of your lecture. And we think you may avail them of these copies. So this is a gift from the university. Congratulations again. Sit down. What am I supposed to do again? Thank you, ladies and gentlemen.
Please put your hands together for the chairman. Before I take announcements for refreshments, please permit me to recognize Professor Matt Agaji. Appreciate him. know that we see you and we appreciate and recognize you. Give it all up for them, please. The Deputy Vice Chancellor's office, for those who are, okay, the past inaugural lecturers, principal officers, please, you'll be entertained at the DVC's office. I'm sure you know where that is. Then, you plus the Chapel of Redemption Resource Main Hall Center, please. UNTH and Niger Foundation plus Open members, you'll be entertained there. Then the hall beside the main hall of that same the clergies and I can't see this writing. Oh, religious. Okay, so all you Kochukus here, just go there for your entertainment. The hall beneath the main hall of the Chapel of Redemption Resource Center. Reverend sister, reverend fathers, reverend sisters, every religious member, please go there for your entertainment. Then the hall below the main hall, Nise and Onidi community, please go there for your refreshment. I know you all are, you're not familiar with that place. It's Chapel of Redemption is just here. So when you get there, ask questions. But before you leave the hall, just ask for direction. Nise and Onidi community members, please, you'll be entertained there. And lastly, every other guests and students, please, you'll be entertained in this CBN hall. Should I take that again? Should I take it again? Yes or no? The no have it. Ladies and gentlemen, permit me to hand the microphone over to the chairman of Senate Ceremonials. Mr. Chairman.
Thank you, Choice. Good afternoon, everyone. On behalf of the Chairman, Senate Ceremonials Committee, Professor Ezeome Onozurike, I express our unreserved gratitude to the Vice Chancellor and the University Management for allowing us gather again to enjoy such a wonderful lecture. We want to thank the inaugural lecturer, Professor Ezeome, for treating us to this topical issue, and for me, it's timely also. It's a rare opportunity for us to have her speak. If we were to pay, probably some dollars would have rolled out to that. Thank you very much, ma'am. Okay, in line with further appreciation, I want to thank especially the Department of Music. They have been consistent and very conscientious to duty. We enjoy them every day we come around there. It's really, really interesting to have you. I urge you to continue what you're doing. We appreciate it very much. Thank you. The ICT unit also, we see what you do and we thank you for making our eyes don't go blind on the screens. Yeah. The guests, our lecturers, our staff, if you didn't come, the inaugural lecture would look funny. It wouldn't have been impactful. Thank you for always coming out and not complaining about participant fatigue. We hope you continue doing this. Thank you very, very, very much. We have some other announcements of our events. Two major events. You might have seen the invitation cards for the convocation, the 55th convocation of the University of Nigeria. It's going to be as grand as it has always been. Make dates for the university from 22nd of this month, Wednesday 22nd, to Saturday the 25th. That's when our convocation ceremony will hold. Then after that, the Thursday after that, we'll return to our usual inaugural lecture series. That will be the 246th inaugural lecture of the University of Nigeria. To treat us to a topic that will be quite engaging will be Professor Chidi Ugu. He's here with us. Professor Chidi Ugu, may we see you, please? Yeah. He is a professor of anthropology. He'll be taking us on the topic, surfacing the doubleness of the gaze towards an anthropology of subaltern agency. His date is Thursday, the 30th of July, 2026. It will hold at the Princess Alexandra Auditorium. Well, when you come, you hear him speak, and he's an erudite scholar, I promise you. Thank you very much, sir. Yeah. Once again, I appreciate everyone who has come, and I pray God, as you leave, He takes you back to your various homes and you meet your loved ones in one piece. Thank you very much.
Can we put our hands together for the chairman? Senate ceremonials. Now I'd like to hand the microphone over to the chairman of this occasion to declare the event closed. Thereafter, we'll invite Professor Chidi to come give us a closing prayer. Mr. Chairman, sir.
I will say it has been a good day for me, and I'm sure it has also been a good day for you because I learned a lot. I don't have much to say again. I will only say that we give God all the glory for today's event. And on behalf of the Vice Chancellor, Professor Simon Uchenna, I declare this event closed, officially closed. Thank you.
Thank you very much, Mr. Chairman.
Okay, thank you very much, Chairman and everybody. Professor Ezeome requested me to say a word. Professor Onzulike, just to say a word about the topic of the lecture. So I'm a professor of anthropology, professor of health anthropology. So some of you may have heard professor of medical anthropology. So I don't refer to myself as a professor of medical anthropology because what we do as anthropologists who are interested in illness and sickness and health seeking is beyond the medical experience. It includes things like prayer, divination, and all sorts of other things. So I think calling it medical is limiting. So I'll say more when we meet at PAA. So thank you very much. My lecture will try to argue, I know that time is fast spent, that unlike the arguments that people have been making about the transnational homogenizing agencies being a source of pressure, changing the other societies and forcing other social systems to change. My argument is that societies, communities around the world are not changing in the way we think they are changing. That they are just putting up smoke screen of change to deceive the forceful external forces to allow them to exist in a way that is masked in some cosmetic change. Okay, so thank you. So I thank you very much. If we rise, I will say a word and we. So, in the name of the Father, in Jesus' name, God, we thank you for bringing this lecture to a successful close. We ask you to help those who will eat, to eat well, and to eat moderately, and not be stuck, a bone. We go back out of Enugu for you to lead them home safely. In Jesus' name. Thank you. In the name of the Father.
We'll take "To God Be the Glory," second stanza.
Great things He has taught us, great things He has done. Jesus the Son, both pure and higher and greater will be our wonder, our transport when Jesus we see. Praise the Lord, praise the Lord, let the earth hear his voice. Praise the Lord, praise the Lord, let the people rejoice. Oh, come to the Father through Jesus the Son, and give him the glory, great things he has done.
Last stanza of the national anthem.
O God of all creation, grant these our one request. Help us to build a nation where no man is afraid. And so with peace and plenty, Nigeria may be blessed.
Please maintain your standing positions and allow the members of the high table leave the hall first. Maintain your standing position and allow the members of the high table leave the hall. Once again, we want to remind you that the convocation event will start on the 22nd of this month. Endeavor to check your emails to see the lineup of activities that we have for the event. God bless you all for coming. Thank you.
Oh, don't you know I love you so. Don't use me to play yo. I sang better one Ijeoma. Oh, don't you na me and you there yo. Don't use me to play yo. I sang better one Ijeoma. Think again. Hey, oh, don't you know I love you so. Don't use me to play yo. I sang better one Ijeoma. Oh, don't you na me and you there. Don't use me to play yo. I sang better one Ijeoma. Hiya, que Messia Gadi, baby, hey, hey, na me and you there, yo. Don't use me to play yo. I sang better one Ijeoma. Hey, yeah, que Messia Gadi, baby, hey, hey. Na me and you there, don't use me to play yo. I sang better one Ijeoma. Hey, na me and you there, yo. Don't use me to play yo. I sang better one Ijeoma. If I na me and you there, yo. Don't use me to play. I sang better one Ijeoma. If you me, hey, be a you say. Mona get be no do. If you want, Biale, yeah. You say, Mona get be no do. My fried rice, Mona get be no do. Hey, my jollof rice, my fried rice. You say, Mona get be no do. Hey, que Messia Gadi. Ah, baby. Hey, hey, hey. Na me and you there, yo. don't use me, they play yo. You say, that's a better one, yo. Messia, Gadi, baby, hey, 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 now me and you there. Don't use me there. I sang better one, yo, man. Now me and you there, yo. Now me and you there, yo. Hey, don't use me there, play. I sang better one, yo. One more. Now me and you there, yo. Now me and you there. Hey, use me. You did, now me and you. I easy. 1, 2, 3, go. A big man of fair. Joe me. Oh yeah, a big man of fair. Joe me. Oh yeah, a big man of fair. Oh yeah, a big man of fair. Joe me. Jomi, hey, bese, Jomi, oh, Jomi, bese, Jomi, oh, Jomi, bese, Jomi, oh, Jomi. Oh yeah, say, a big man affair, a big man affair, oh yeah, a big man affair, Jomi, yeah, Jomi, oh yeah, a big man affair, Jomi. Johnny, every man of Johnny, every man of Johnny, every man of Johnny, one more, every man of Johnny, every man of 1, 2, 3, go. You say, you say, that soup where you cook last night.
Yeah, too.
That soup where you cook last night. That soup where you cook last night. That soup, darling, once more. That soup where you cook last night. See, that soup where you cook last night. Oh, that soup where you cook last night. Say that soup, hey, hey, that soup where you cook last night. Hey, that soup where you cook last night. Hey, that soup where you cook last night. That soup where you cook last night. Hey, that soup, darling, once more, darling. And yeah, that soup where you cook last night. That soup, darling, once. Hey, that soup where you cook last night. That soup, hey, darling, once more.
Yeah.
That soup, hey, I say that soup where you cook last night. Yeah, that soup, darling, once more. I say that soup where you cook last night. That soup, hey, darling, once more. Hey, that soup where you cook last night. Yeah, that soup,